evening, everyone. I'm Dr. Shailesh Gupta. Today, I'm going to talk on functional tumors of pancreas. These are the very rare pancreas. Generally, in a clinical practice, we rarely able to see them. But this topic is very important topic in terms of a theory examinations. And being a functional tumor, so it is also very interesting to read about them. So, uh, so uh, pancreatic neuroendocrine tumors are divided into two parts: functional tumors and non-functional tumors. So today I'm going to discuss about functional tumors, which include insulinomas, gastrinomas, vipomas, and gluconomas. And these produce specific hormones which causes syndromes. Apart from functioning pancreatic tumors, there also are non-functioning, which are usually have a more percentage as compared to functional one. They do not produce any syndrome due to hormonal excess. Rather, they cause morbidity and mortality by invading the normal tissue and by metastasizing to the other organs. So first, I'm going to discover insulinoma. So as an introduction, most important thing is that insulinoma is the most prevalent functioning tumor as compared to other ones. Also rare, but among the functional tumor, it is the most prevalent one. So it is a most common cause of a hyperinsulinemic hypoglycemia in adults. This condition exhibits a slight female predominance, with the median age at a diagnosis is typically occurring in the 5th decade of life. So basically, there are typically solitary lesions that are small, 90% are less than 2 centimeter. They are well circumscribed and equally distributed throughout the pancreas. So solitary, smaller, and equally distributed throughout the pancreas. Rarely, insulinoma occur as a multiple lesion also, and this is usually associated with the Mann-1 syndrome. So 90% of insulinomas have been reported to be benign, and greater than 90% occur at the intrapancreatic site. So all these points are very important for a theory examination, and also very frequently asked in NEET SS. So coming on to the clinical features, insulinoma produce a greater amount of insulin, which leads to hypoglycemia. So all the symptoms of the insulinoma are centered around the hypoglycemia. And the most important thing is Whipple triad. This is a very important theory question. Whipple triad consists of symptom of hypoglycemia, which means symptoms like confusion, sweating, and palpitations, documented low blood sugar level, and symptoms of hypoglycemia get rapidly resolved with glucose administration. So these are the 3 points which comes on the Whipple triad: hypoglycemia, symptoms, low blood sugar levels, and immediate relief of the symptoms on glucose administration. So apart from it, neuroglycopenic symptoms are also there, which are confusion and cognitive impairment and seizures. Autonomic symptoms like sweating, palpitations, and tremors are also seen with insulinoma. So some individual may have an increased appetite, and there is also a paradoxical weight gain. This happens because of the excess insulin production. So how will you evaluate the insulinoma? How will you diagnose the insulinoma? The initial step is in evaluating the patient with hyperinsulinemic hypoglycemia involves establishing the Whipple triad with symptoms of low blood glucose level, serum glucose level below 50 milligram per dl, and symptom resolution with the glucose intake. This is basically a Whipple triad. Following triad confirmation, insulin level should be checked. Inappropriately normal or elevated insulin level coupled with hypoglycemia are indicative of insulinoma. But it is very important that we should exclude exogenous insulin administration or hypoglycemic drug. So basically, clinically, we need to see about Whipple triad, and biochemically, lab parameter, we need to see the insulin level. And we need to rule out the exogenous insulin administration or hypoglycemic drugs. So once the hypoglycemia symptoms due to suspected insulinoma are confirmed, the tumor should be localized prior to attempted surgical resection. So now we have made a diagnosis of insulinoma. Now it is very important to know the location of the tumor, because it will help us to plan the operation, and it will also avoid the extensive exploration. So the best modalities are multiple and they depends on the local experience and the availability. CT and MRI have the 30 to 60% range of identifying the insulinoma. As these are the small tumors, CT and MRI have a deficiency in locating them. So angiography along with the calcium stimulation and venous sampling was previously considered the gold standard, but now as endoscopic ultrasound has come, it has a sensitivity of 93% and specificity of 95%, which is a more common method for localizing the insulinomas. And intraoperative ultrasound are also useful in localizing small tumor, and they're better than EUS as there is no or minimal interference of overlying organs of bowel gas. So to summarize these two slides, endoscopic ultrasound, ultrasound are at present gold standard to localize the insulinomas. Insulinomas are of small size, so CT and MRI are not accurate as compared to other tumors. Angiography is the invasive method. It was previously considered to be a gold standard, but now rarely used. So imaging methods like GLP-1 receptors targeting have been recently introduced. GLP-1 receptors are highly expressed in insulinomas. So GLP-1 combined with radioisotopes and are infused into the patient, and planar images and PET scan is done. So these tumor get due to the uptake of radioisotope scan, they get lightened up in the PET scan. So here I am showing you a CCT image. So typically insulinomas are hypervascular. So they demonstrate a greater uptake of the contrast as compared to the surrounding pancreatic parenchyma. So they get more lighten up in the CT. So here you can see a arrow is marked over the insulinoma. So now this is the MRI image. Here we can see the insulinoma generate the low signal intensity on T1 images and high signal intensity on the T2 weighted images. So this is a image of endoscopic ultrasound. Here in between the arrows, we can see the insulinoma, which is homogeneously hypoechoic and rounded in shape. Now this is a angiography and arterial stimulation venous sampling. Here we can see there is a vascular plushes that are of area of increased vascularities compared with the surrounding normal pancreatic parenchyma. So because of the more vascularities on angiography and arterial stimulation, they are visible. So how would you treat the insulinomas? As we know that 90% of them are benign and 90% of them are inside the pancreas. So surgical removal of insulinoma is the best treatment because it is curative in 85 to 95% of patients. Medical management is only done in unresectable or metastatic tumors, and traditional medication like diazoxide, calcium channel blockers have limited values. Somatostatin analogs and mTOR inhibitors have been demonstrated dramatic effect in controlling hypoglycemia and reducing tumor burden. So basically, these are the supportive treatment, not a curative treatment medicines. Genetic markers such as microsatellite instability and MLH1 gene inactivation may be helpful in predicting the insulinoma behavior. So this is a